Good evening. My name is Mary Villas, and I am the president of PSC Partners Seeking a Cure Canada, together with Ricky Safer, CEO and founder of PSC Partners Seeking a Cure. We welcome you to the second webinar in the post-conference educational series, the PSC-IBD Connection, with speakers Dr. Josh Korzenik and Dr. Joel Pekow, and moderated by Dr. David Assis. Next slide. This webinar and the remaining of the educational series, part of the 2022 annual conference programming, have been made possible with the generous support from our sponsors. To the many community sponsors shown here who have been steadfast in supporting the work of PSC Partners, thank you. Next slide. And another huge thank you to the 2022 annual conference corporate sponsors shown here: Gilead, Pliant, High Tide, Mirum, Escient, Perspectum, Colorado Children's, our co-hosts, Brigham Health, Mass General Brigham, and this project is supported by the Chan Zuckerberg Initiative. Next slide, please. On June 2 to 5, the 18th PSC Partners Annual Conference was held. So much gratitude to our co-sponsors, Dr. Korzenik and Dr. Pratt. The conference exceeded our expectations, and over 500 patients, caregivers, speakers, researchers, and clinicians joined for the launch of the PSC Partners Collaborative Research Network. If you missed it, or if you'd like to rewatch any of the general sessions, all of the videos are available on the PSC Partners website at the link shown here, go.pscpartners.org/2022-conference. Next slide. Please mark your calendars and join us for the remaining upcoming post-conference educational series of webinars. You will find links to register at the events page on the PSC Partners website. Please note that the July 27th webinar with Dr. Schoferman, Living with PSC, Psychosocial Stresses and Strains, Coping Strategies for Patients, was canceled due to an emergency and will be rescheduled. So please stay tuned. All right, to you, Ricky.
All right, thank you, Mary. Hello, everybody. And thank you for joining us tonight for a fascinating session on the PSC-IBD Connection, a challenging yet promising topic that, once better understood, could lead to new pathways for PSC research. Before introducing tonight's speakers, I'd like to give a shout out to all the dedicated clinicians and researchers who continue to be so dedicated to helping our PSC community. They volunteer their time to present at our webinars and conferences and are always available to answer our questions and guide us on all of our projects. We are very appreciative of their passionate support. Speakers Drs. Josh Korzenik and Joel Pekow are both gastroenterologists who are experts in IBD and who also have a great interest in PSC and figuring out the connection between these two diseases. I'd like to first introduce tonight's moderator, Dr. David Assis. Dr. Assis is an assistant professor of medicine, section of digestive diseases, medicine department at the Yale University School of Medicine. His clinical and research interests are in autoimmune liver diseases, specifically focused on autoimmune hepatitis and PSC through both clinical work and translational and basic research. Dr. Assis is also a longtime member of PSC Partners Scientific Medical Advisory Committee. I'll turn it over to you now, Dr. Assis.
Hello, and thank you, Ricky. Thank you, Mary, and thanks for all of the patients, family members who are joined us to participate this evening. This is a very exciting session, and I'm happy to get it started. We will first be hearing from Dr. Joshua Korzenik, who will be talking about the connection between PSC and IBD. Dr. Korzenik, as you can see there, is the director of the Resnick Family Center for PSC Research and also the director of Brigham Women's Crohn's and Colitis Center. He has a keen interest in this connection, and his research is focused on developing new therapies for PSC, really predicated on an understanding of the connection between PSC and IBD. So a very appropriate speaker for this topic. Thanks so much, Dr. Korzenik.
Great, thank you, David, very much. Thank you Ricky and Mary. I'm really delighted to be here and glad that you've chosen to spend some of your relaxed summertime with us. I think that this wonderful organization, as embedded in the name, is Partners Seeking a Cure, PSC. And that's a bold sort of name. And we very much want to get there. In order to get there, we really need to understand what causes PSC. And in order to understand what causes PSC, we look at all sorts of clues. And so the best clue we have, even though we might find a little bit of clues of maybe there's a slight impact of coffee drinking, maybe there's a slight impact on other components of some of the medications or smoking or things like that. But by far, the most significant clue we have is that there's this close association between PSC and IBD. And it's really curious in terms of living in coming from the IBD world as opposed to from the liver world. We see things a little bit differently, and we tend to see it as though that's a liver disease, and liver tends to see GI as well as a GI disease, as opposed to trying to do what we're all now engaged in, is trying to understand how they really fit together. So what I'm going to do in the next 20 minutes or so is just review what understanding we have. Are these sort of bound at the hip? Are they really closely related? And how do we then take that information and try to take the next step to what studies should we be doing to understand the diseases better? How do we understand how they are connected up? And then taking that step further, how do we then treat that change or that association? How do we make sense of it to come up with a therapy that might be helpful? Next. So let's start with just saying, well, how are they connected? And many of you, I'm sure, are very familiar with this. It's maybe about 3 to 5% of individuals with ulcerative colitis have PSC. It's some are as little as 2, as much as 8% overall in looking at studies. And the vast majority of people with PSC have ulcerative colitis, though some have Crohn. So it's about 70 to 80% of people who have PSC will have ulcerative colitis. It ranges, but this is seen throughout the world, though that may vary a little bit depending on how big the population is and what's being looked at and how that's being decided or determined. Now, it's less likely with Crohn's, though some studies have suggested, one important one from Canada suggested it may be similar, but for the most part, we'd say that it's about 80% of those with PSC that have IBD have ulcerative colitis. Maybe about 15% of those with PSC and IBD have Crohn's disease. And then that remaining group are fit into a category that have some characteristics of Crohn's, some characteristics of ulcerative colitis. We can't quite decide, and I'll show you why some of that could be confusing. But it's also that indeterminate colitis can be a little bit of both. What I want to say is that some people get a little confused. You can't have both Crohn's and ulcerative colitis. You have one or the other. And this, if we can't decide, it fits into this category. Now, sometimes someone can have PSC for a while before IBD, but we're aware of this association enough so that clinically, if anybody is diagnosed with PSC, they always should have a colonoscopy to determine whether there is inflammatory bowel disease, even if they're not symptomatic, because it can be less symptomatic than one would expect. Next, please. So the first question that we really want to think about is ulcerative colitis that is either with PSC or without PSC the same disease? So do we think of these as, yeah, they sort of look the same, but can we really rely on them as being the same when we're trying to understand disease process and other things? And in ulcerative colitis, it's more often pancolitis. Next. And about 25% have what we call backwash ileitis. So just a brief word about this is the backwash ileitis is when the ileum, so the last part of the small bowel where it connects up to the colon, is called the terminal ileum. And usually ulcerative colitis comes up to the cecum if it's pancolitis, up to that last part of the beginning part of the colon, and then it stops. So if you have ulcerative colitis and you have ileal involvement or the small bowel involvement, let's say that's Crohn's. However, people can have this element that's called backwash ileitis, where there's possibly a little bit of reflux back from the colon into the ileum. It causes a little bit of inflammation. It's not these deep ulcerations we see with Crohn's, and sometimes it can be subtle. Typically in ulcerative colitis, pancolitis without PSC, it's maybe about 10% of backwash ileitis. In people with ulcerative colitis and PSC, it's about 25%. And here in the first statement, I should explain a little bit more that ulcerative colitis without PSC, about half the time presents with just the left colon involved. And about 50% of those people will eventually extend to be pancolitis, but you can have less than the whole colon involved, whereas people who have PSC, their ulcerative colitis tends to be the whole colon involved. One of the things about ulcerative colitis that characteristically it starts in the rectum and works its way back. It may be just the rectum, or what we call proctitis. It may be the rectum and a little bit more, called proctosigmoiditis. It may be the whole left side, it may be the whole colon, but it's almost always starts in the rectum and works its way back. Most often, or nearly almost always, in ulcerative colitis, the rectum is involved. In people with ulcerative colitis and PSC, there can be something called rectal sparing, where there can be either relative sparing, where there's less inflammation, but there's still some, or there's really normal lining of the intestine there. We don't see that usually in people without that. So is that a different disease, or is it just sort of a slightly different variation? Next, please. So it's curious because most often Crohn's sometimes will just involve the small bowel. Sometimes it can involve higher up in the small bowel, but people who have Crohn's with PSC tend to have Crohn's colitis. Why that is exactly, we're not sure. Whether that really is a variant ulcerative colitis is really Crohn's, we're not sure. But one of the things that is clear that we're very vigilant about is that those who have PSC compared to those with ulcerative colitis and PSC compared to those with ulcerative colitis without PSC, those with PSC have a greater risk of colon cancer. So both groups, whether there's PSC or not, we're very vigilant. But with someone who has PSC, we start and do screening every year. And somebody who has ulcerative colitis without PSC, the first 10 years, we tend to do it every 3 years, then every 2 years for the next decade, and every year after 20 years. But in PSC, because of the greater risk, we start right off the bat. Next. Now, when we look at more subtle ways of defining the disease, so saying what proteins are expressed, what proteins are present in the lining of the intestine, studies we've done and other people have done, there's really minimal difference. There's occasionally some very minor, very subtle differences, and whether that's really the heart of the disease or not. So when we're trying to compare these on a broad scale of saying, is the whole colon involved or not, there doesn't seem to be a major difference. There's some subtle differences. When we look at the gene expression, what is going on in terms of the proteins at the level of the lining of the intestine, there really doesn't seem to be a significant difference between the two diseases. So even though some people would say it's a distinct disease, and often hepatologists will say, we do think it's a distinct disease, I don't think so. And I think that certainly we'll see many people who have ulcerative colitis before PSC, and it's indistinguishable from someone else who has ulcerative colitis, and then they'll go on to develop PSC. So we want to understand that, why someone goes on. But I'd say that my feeling is, and many people would agree, that there is that ulcerative colitis is really with or without PSC is the same fundamental disease. Next. So the next question then is, how does IBD influence PSC? Well, there's a slight milder outcome in people with PSC and Crohn's, than people with PSC. So there's even a suggestion that it tends to be more women with Crohn's will get PSC, more men with ulcerative colitis will get PSC compared to those otherwise. But when you compare PSC and ulcerative colitis to PSC and Crohn's, that it seems like the people with Crohn's and PSC have a milder outcome than those with UC. And what's very curious also is that often, even if the inflammation is quite significant, the GI symptoms can be milder. So it's something we're very attuned to, because sometimes my patients with PSC will say, well, I feel fine. We'll do a scope, or we'll get a stool test for inflammation called calprotectin, and it's quite elevated. And so, yes, symptoms are really important, but we also want to make sure we can do everything we can to try to get the disease under full control. Next. So can we impact the liver disease by getting the GI disease under control? Now, one of the things that's so challenging, infuriating, difficult about PSC is that we have a host of therapies that are reasonably effective or very effective for inflammatory bowel disease, but none of them work with PSC. Why that is isn't clear, but at least it gets the GI disease. But getting the GI disease under control really doesn't have a big impact on the liver disease. For some of the what we call the extraintestinal manifestations of IBD, so if you have, say, arthritis, or you have hip pain associated with your ulcerative colitis, if we get the ulcerative colitis under control, most often that hip pain will resolve and get better. The same is not true of PSC. So that if you get the GI disease, the colonic disease, the inflammation to resolve 100%, it doesn't seem to have a significant impact on how inflamed or how actively inflamed the liver disease is. So there's also a suggestion that worsening colitis is associated with milder liver disease, and those who undergo liver transplant, at least in one series, were more likely to have milder colonic disease. It's a little bit paradoxical, because you'd think if they're going in tandem, if they're going together, if you got the GI disease, the liver disease should get better. And if they're going in tandem, if you have worsening colitis, you'd think the liver disease would be worse. But it doesn't seem to be quite the case. So again, untangling and understanding this relationship gets a little bit more challenging when you go into some of the details. Next. And then what's also curious is the type of liver disease may be slightly different, that PSC with Crohn's disease tends to be more small duct disease. PSC with ulcerative colitis tends to be large duct disease. Next. So we've just talked about how IBD influences PSC. The second question is, how does PSC influence the IBD? So what is this interplay? And when we look at, are there different clinical presentations for PSC with IBD compared to PSC alone, there tends to be more intrahepatic and extrahepatic involvement in PSC alone. But microscopically, when we look under the microscope at these two different characteristics, that really doesn't seem to be very different. PSC with IBD seems to be more likely to need a liver transplant than PSC alone. So it may be, even though it doesn't look that different, it may be a slightly milder variation of the disease if you don't have the colonic component. Next. So if we do a more radical therapy, if we have refractory disease, or for other reasons, if someone has colon cancer and needs to have a colectomy and then a J pouch, so the last part of the small bowel is turned into a J, the colon is taken out, and the J is put where the rectum is, so that somebody moves their bowels as they would otherwise, so the colon is taken out. The question is, how does that then influence it? And having a colectomy, it's not something that we would recommend just for this reason, but it does have a mild influence on PSC outcomes. So in some studies, it's not huge numbers, but that seems to make the PSC disease course a little bit milder. And those who have had transplant and colectomy have a lower chance of recurrent PSC. So again, a suggestion that there may be some interplay between the colonic disease and the liver, which can make it milder if it's less there. Having said that, though, those with PSC are more likely to have pouchitis, so inflammation in this J pouch after colectomy than are those who have ulcerative colitis, have a colectomy, and have a J pouch. So those with PSC are more likely to have pouchitis. Next. So as I mentioned, it's really curious and frustrating that none of the therapies that are effective in IBD work in PSC. There is maybe a suggestion that 6-MP and azathioprine might work in a retrospective study of fairly sizable from Sweden, that there's a possible benefit, but it may have a benefit more in further stages than just in really progression after cirrhosis has already developed. There's also a possible benefit of sulfasalazine. So sulfasalazine was the first version of mesalamine. Many of you may have been on mesalamine that go by various names, whether it's Nialda, Azicol, Prizo, Colazole. Those are all the same medication, mesalamine. Mesalamine does not get to the liver, but sulfasalazine does. It's not detoxified, or it's not metabolized by the lining of the intestine. It gets to the liver and it gets to the biliary tree. And so there were two retrospective series, one from Japan and one of ourselves, which we've submitted for publication, which suggests that there is a benefit in reducing alkaline phosphatase and possibly a longer term benefit with sulfasalazine. So we've been doing a clinical trial. We're hoping to complete it in the next 6 months, small trial, and a placebo-controlled trial with people then getting an open label. And we'll see if there's an inkling of a benefit with sulfasalazine in PSC, and whether that sort of supports the retrospective series, meaning looking back, people who were on sulfasalazine for other reasons. Often it's given, say, for arthritis as well, and so did that help the liver disease as well? So we're looking to see and whether that would potentially be a therapy that we could use that's currently approved for other reasons. Antibiotics are not effective in ulcerative colitis, but there's a controversy whether they might be beneficial in PSC, and particularly vancomycin sometimes is used, and particularly by the pediatricians for ulcerative colitis, and there's a question whether that might benefit PSC. Next. So how are they connected in terms of things? That there's a genetic overlap in terms of risk factors, but the genetic influence overall is relatively mild. It's not what we call a monogenic disease where there's one gene. If you get that, you're highly likely to have it. It's about 50% of the genes between these diseases don't overlap. Some share, and some are distinct for PSC, some are not. So that there is likely a genetic influence, but whether that's primary in the development of the disease, how that relates to the disease, all that we're trying to figure out and understand what goes on. So how then might they be connected? Well, there are a number of hypotheses. One is that sort of a leaky gut, that the bacteria basically drains into the liver and is filtered out. Some of the metabolites there are filtered out. And is there an increase in permeability? More of these toxic compounds go across into the liver, and does that cause it? Is it that the inflammatory response in the GI tract cross-reacts with something in the liver in a small subset, and that causes the trouble? Or is that there's some type of bile that both causes trouble for the colon, and increasingly we're recognizing that there may be a role of bile acids in causing colitis, or at least in association with contributing or be part of that picture? Or is it something totally separate? And is that aberrant or bile acid that's a problem in the colon also a problem in the biliary tree? And it's important to recognize that as much as 75% of the blood supply from the liver comes from the intestinal circulation. So the liver is getting a lot of what's being put out from the colon. Next. So how do we try to understand, take this information and understand PSC? One way is certainly looking at these genetic, microbial, and environmental clues and seeing how they what they tell us. So as an example, coffee consumption may reduce the risk of developing PSC and may have a modest association with the disease course. That's modest at most. Next. Smoking tobacco reduces the risk of PSC and ulcerative colitis. And after quitting smoking, there's a higher risk of ulcerative colitis than never smokers. So it's not just that smoking reduces the risk of ulcerative colitis. When you quit smoking, that's a greater risk than if you had never smoked. So how do we understand that? There's a similar impact that quitting, that's not quite the same in that smokers seem to have a lower risk of PSC, but after quitting, they still have a lower risk. So I wouldn't recommend anyone start smoking. That's not going to help you overall, but trying to understand these as important clues. So there's some suggestion, as much as there may be a benefit of antibiotics in PSC, possibly in Crohn's. Antibiotic use may also be a common factor that changes the microbiome, the intestinal bacteria, that then influences the risk of ulcerative colitis, Crohn's, and maybe PSC. And so there's certainly case series and reports of people who go on a particular antibiotic and then develop PSC. That's not a reason not to go on the antibiotic. Those are fairly uncommon, but it just increases the risk. And so we need to understand how that microbiome is changed. Next. So another factor may be oral contraceptives. It may actually decrease the risk of PSC, but it may increase the risk of IBD. That's a little less clear. And it may be a secondary effect. It may be in terms of clotting cascades or other things. And it may be that the older contraceptives had a greater impact than the more recent lower dose contraceptives. Next. But having said all these various things that are important to track down and understand, the most important clue, as I mentioned at the beginning, is this link between IBD and PSC. So how do we go about studying PSC to understand this better? Next. So I think we take the assumption or the understanding at the Resnick Center that to understand PSC, we need to understand ulcerative colitis, and to understand ulcerative colitis, we need to understand PSC. This link is critical to understanding both diseases. Next. So when we look at these diseases, often, and this is for any sort of so-called autoimmune disease, and whether these are genuinely autoimmune in the classic sense, we are questioning that, and it may have other causes. But we see this as this interaction between a genetic susceptibility, something about the gut microbiome that's really important, something about immune response, and other environmental triggers that all come together. And those people that have enough of these unfortunate risk factors that come together are this subgroup of people that will develop either IBD, and then a subgroup will develop PSC. Next. We think that probably the microbiome and environmental triggers are most important. We think that environmental triggers get a little bit short shrift, and genetics and immune triggers get sort of perhaps overplayed. And maybe it needs to be balanced a little bit. And I think probably the microbiome maybe should be put here as well as one of the more fundamental triggers. And so we're trying to understand that right now. Next. So understanding the disease interaction, the genetic clues we touched on a little bit. And just to mention a little bit more, next. There are overlapping genes, but the genetic influence may be a stronger link to PSC and ulcerative colitis than to PSC and Crohn. So the 16 genes that are most closely associated with PSC in some of the larger screens, it's probably just half of them overlap and are associated with IBD. So there's a clear overlap, but there's also something that's distinct and separate. Next. And here, this was the largest study, and you see the numbers here. The strongest link, this gene called UBASH3A, was not associated with ulcerative colitis. So is it that you get ulcerative colitis and then you have another risk factor that takes that ulcerative colitis and turns it into something else? Next. And still, even having said that, this is pretty modest. So even in the best studies in IBD, where the genes have been more significantly assessed, at most, and I think this is an overcall, it maybe accounts for 20% of the risk of IBD. And I think it's probably less than that when you look at a number of studies. And it's even less in PSC. Next. And then it's important to look at some of the genetic factors in that, is it the primary initiator or it's a secondary modifier? So meaning something else may be happening to start the injury, but then to turn it into a more chronic persistent disease, maybe you need something else. So maybe the original initiator may be a very common issue, but only a subgroup are going to take that, not heal, and turn it into a chronic issue. So the genetics may not be the causative factor, but it may be an important contributor to persistent disease. Next. So one of the things that we're working very hard on, and many other people are working on, and you'll hear more from Joel in a second about the microbiome, is there, how is the microbial makeup related to both PSC and ulcerative colitis? We know that there's a reduced diversity. There's a huge number of bacteria. You'll hear more about this shortly. There is a distinct but overlapping microbiome in PSC compared to PSC and UC, but it may be that functionally they're doing very much the same things. Next, so meaning it's not just who's present, but they have all sorts of metabolic properties. They're doing all sorts of things. So here's some of the names of some of the bacteria. What are they doing there? It's not just as an infection, but they're putting out metabolites, they're putting out different substances. What are those substances, and how is that causing these diseases? One study from Norway showed there's a decreased vitamin B6 synthesis and also something called branched chain amino acid synthesis in PSC related to the microbiome. Is that directly important, or how is that important? And they're investigating that further. Next. So it's interesting, Veillonella may be one of the stronger, and not in all, but many series may be strongly associated with PSC. What are they doing? Are these diseases fundamentally caused by what we call a dysbiosis? And how do we change that? And so we're very interested in that. We're in the process right these weeks, sending off hundreds of samples, both the intestinal bacteria, oral bacteria, and what we call metabolomics, and understanding what they're doing. And hopefully we'll have some findings in the year ahead to present to you to explain some of these things, at least what our findings are. Next. So are any of these, well, how do we take these and then turn this into a therapy? So we're trying to understand the disease interaction, and again, why are the medications that are effective in IBD not effective in PSC? So we're trying to understand that, understand how some of these things impact the liver, and why is it that they're not effective? So that's a question in itself that we're investigating. Next. So does it mean that the immune reaction in PSC is different? So that when we look at whether it's something like an infliximab, Remicade, or adalimumab, Humira, which can be effective, it doesn't really modify PSC. Does that mean that TNF, which is what is the target of these drugs, is not important in PSC, or is the immune reaction very different? So trying to understand, or is the nature of the injury different? Is it that it just doesn't provoke the same kind of immune response because the type of injury that's going on is different? And then is it that it's a different immune response, meaning how does the liver heal? And is that different than how the intestine heals? And how do we understand that to then interfere with that or promote that in a way that's going to be more effective as a therapy? Next. So are we really looking at PSC with the wrong framework? It's curious that all of the therapies that have been looked at, perhaps a mild effect with steroids, perhaps a mild effect with 6-MP and Imuran, but so many different immune regulatory drugs have been tried in PSC, and they haven't worked. So are we looking at it as an autoimmune disease? And yes, there's an immune reaction that's important. Yes, there's an important sort of inflammatory response that's obviously central to the disease, but is it truly autoimmune? Or are we just saying that because we don't understand what causes PSC or ulcerative colitis? Next. So is it really not an autoimmune disease? I know that for many of you may seem like, well, isn't that crazy? We all know it's an autoimmune disease. Well, again, I think that sometimes we call it autoimmune because we don't understand it. It may be autoimmune in a different way, meaning is the immune system really reacting against a component in the liver and trying to direct an inflammatory response against it, or is it autoimmune a different way? Are we making autoantibodies to other factors that influence pathways that may then generate injury? Next. So we're looking at this to say there's not one cause, there's not one bacteria or virus. It's a complex set of interactions. It's clearly an interaction between the microbiome and the liver and the gut. And we're developing a set of specific hypotheses that we're trying to look at and test. And so we'll be testing one of these in the near future with a new therapy and looking at the microbiome in this. So this is how we're trying to take the clues we get from ulcerative colitis and PSC and directing it into a therapy. So steps forward. We need to increase crosstalk between those that research in PSC and research IBD. So we want to raise the profile of PSC in the IBD community so that there's more interaction. We can use what we've learned from IBD to try to see whether it might apply to PSC, and the same way in the other direction. We need, I think, to recognize that these two diseases are interconnected in terms of fundamental causes and understand what's the nature of that interaction. And we have to have an appreciation of the medications that can help in ulcerative colitis don't help in PSC. So what's distinct and different? So all of these things sound just like hypothetical questions, but all of these are things that we're looking at in a very direct and immediate way. We're both looking at it in terms of direct studies, whether it's myself, whether it's Joel, or whether it's David and many others. And we're very excited because we think with the tools that are available now, we're able to start sort of understanding what this relationship is, beginning to understand what the microbiome is, and have ways of trying to modify the microbiome to try to affect that and improve the disease. And so I'll stop there and turn this over then back to David, and he'll hear more then about the microbiome. So,
thank you so much, Dr. Korzenik, for a really wonderful presentation with a lot of provocative questions, which I think we really need to wrestle with as a community and as researchers, clinicians, and patients and advocates. Thank you. And for the audience, just as a reminder, we will have time for an extended Q&A after our next talk. But if we could advance forward. Thank you. So I have a pleasure of introducing Dr. Joel Pekow, who is an associate professor of medicine at the University of Chicago. He's a gastroenterologist with expertise in IBD and has a particular interest in investigating the mechanisms of colon cancer development in patients who have PSC and IBD, a similarly really relevant topic to this session today. So thank you so much, Dr. Pekow.
Oh, thanks for having me. It's great to be with everybody tonight. So what I thought I would do that would be probably the greatest interest to everybody is to delve into a couple areas that Dr. Korzenik had mentioned. One is the risk of colon cancer, and the other is the microbiome and how these relate to PSC, although these two topics don't necessarily overlap significantly. So it's going to be like two mini discussions, one after the other. You can do the next slide. So first off, let's talk a little about the risk of colon cancer in patients with IBD and PSC. Next slide. So when we talk about colon cancer, oftentimes we'll use the term neoplasia, and neoplasia encompasses both dysplasia, which is a precancerous change when we talk about it's in the colon that has a potential to turn into cancer, and dysplasia can be broken down into low grade, so it's a lower risk lesion, or high grade, which is a lesion that has a histology just before or just one step away from turning into cancer. So sometimes during the discussion, I'll use the term cancer, I'll use the term neoplasia, which encompasses both dysplasia and cancer, and sometimes I'll use the term dysplasia alone. And we know that patients with inflammatory bowel disease, so irrespective if they have PSC or not, have a higher risk of colon cancer than the general population. This really only pertains to patients with colitis, so whether they have ulcerative colitis or Crohn's colitis. Overall, this risk is very low, but still higher than what you see in the general population. And somewhat encouraging is that, when studies came out 20 or 30 years ago that said the risk of developing colon cancer was around 18% at 20 or 30 years disease duration. We know from more recent studies that risk is significantly lower. And that may be due to the fact that we have better technologies to detect precancerous changes and resect them or remove the colon before cancer develops. And we have better therapies to treat inflammation, which we know is a risk factor for developing cancer over time. Next. So what are the risk factors in a patient with ulcerative colitis or Crohn's colitis for developing colon cancer? So the main risk factors that are known are having extensive colitis, so having the entire colon involved, having a longer disease duration. So patients who are shorter in their disease course have a lower risk than if you've had a longer disease duration. That's why in some patients without PSC, when we do surveillance, we'll start with a surveillance period further apart at three years or so after they've had about disease for about 10 years. And then as they've had longer disease duration, we'll shorten the interval of surveillance because their risk increases over time. We also know from a few different studies that poorly controlled disease or uncontrolled histologic or inflammation over time increases one's risk. And importantly, PSC is an independent risk factor for developing dysplasia and cancer in the colon in patients with colitis. Some of the risk factors that are seen in patients with PSC overlap with these other risk factors. For instance, virtually everybody who has ulcerative colitis or Crohn's disease with PSC has extensive colitis. And I'm going to show some data on a subsequent slide that patients with PSC actually may be more likely to have more poorly controlled disease activity than those without PSC because they're less likely to be symptomatic, as what Dr. Korzenik referred to earlier. You can go ahead to the next slide. So what are some differences in the risk of colon cancer in IBD patients with and without PSC? So neoplasia in patients with PSC more commonly occurs in the right colon versus patients without PSC, it more commonly occurs in the left colon. Colon cancer, colon neoplasia in PSC patients occurs earlier in the disease course than is seen in IBD patients without PSC. And as I mentioned, PSC colonic neoplasia occurs at a higher frequency than in patients without PSC. Go ahead to the next slide. So what is this risk? This surprisingly is difficult to estimate over studies. And this is partly due to the fact that when patients develop the dysplasia or precancerous changes, it's resected either at the time of colonoscopy or by surgery before cancer ever develops. This is a nice study that was a nationwide database study with a 10-year follow-up. And you can see on the figure on the left there, the risk of colon cancer with time in the PSC patients in blue and the non-PSC patients in red. And you can see the risk is higher, obviously, but still overall low at 10 years of disease duration, so less than 6% risk of colon cancer, but it's about triple the risk of in this study in PSC patients versus non-PSC IBD patients. You can go to the next slide. So can we prevent colon cancer? That's really the big question. And wouldn't it be nice if we had a drug that we could take that would decrease an individual's risk of developing colon cancer? And this is what we refer to as chemoprevention. And several drugs have been looked at in patients with IBD. In particular, in the PSC population, ursodeoxycholic acid has been studied. And the trials I'm showing here were both done in conjunction with looking at ursodeoxycholic acid for treatment of PSC, and then they looked at a subgroup of patients with IBD to see if they developed dysplasia over time. And you can see this older study that was published in 2003 when they looked at a low dose of ursodeoxycholic acid, or 13 to 15 milligrams per kilogram. Patients on treatment were less likely to develop dysplasia with time. However, when a more recent study, although not so recent anymore, when they looked at a high dose of ursodeoxycholic acid, it was actually harmful, and meaning the patients on the ursodeoxycholic acid were more likely to develop neoplasia in their colon. And this is coupled with the fact that this high dose was not shown to be effective for PSC either. So the jury's still out on giving ursodeoxycholic acid for chemoprevention, although no longer recommended routinely. And whether this is a dose effect or if the medicine just doesn't work, or there was some error in one of these trials that led to an aberrant outcome is not known. Go to the next slide. So another possibility is that might decrease an individual's risk for developing colorectal neoplasia is to control colonic inflammation better. So this is a study that we did a few years ago, where we looked at our patients with PSC and ulcerative colitis and PSC without ulcerative colitis who were in clinical remission, so patients who had no symptoms. And we went through their endoscopy and histology reports. And what we found is that the patients with PSC were much more likely to have inflammation, particularly in that right colon where neoplasia is more common than IBD patients without PSC. So this is in the absence of clinical symptoms. So oftentimes you'll hear that when people talk, they'll say patients with PSC have less severe disease activity. And I don't know if that's true. Less symptoms is true, less severe disease activity is not known, but in our study, patients had more severe disease activity when they didn't have clinical symptoms. And because patients don't have clinical symptoms, are less likely to have adjustments in their treatments. They have uncontrolled inflammation, which has the potential to be a risk factor for developing neoplasia. Next slide. And so we did a more recent analysis where we looked to see if this histologic inflammation in patients with PSC increased a risk of developing dysplasia. And what we found is that patients who had less inflammation, less aggregate inflammation over time, were less likely to go on to develop dysplasia. So, and this is similar to what's been seen in IBD patients without PSC as well. You can go to the next slide. So, how can an individual decrease one's risk of developing colon cancer? So from the data I just showed, it suggests that patients with PSC may be more likely to have uncontrolled inflammation in the right colon, and that inflammation may predispose to a risk of colon cancer. What we don't know is that if you reverse that inflammation, does it decrease the risk? And that would be the next study to do, although easier said than done in terms of doing the analysis and looking at a large number of patients. In addition, patients who undergo regular surveillance, so it's recommended for patients with a co-diagnosis of ulcerative colitis or Crohn's colitis and PSC to have yearly surveillance. And with yearly surveillance, these dysplastic lesions are frequently identified early before cancer develops. So we can prevent cancer through this method, or if cancer does develop, identify it early before it becomes advanced. You can go ahead to the next slide. So I'm going to shift gears here now and shift into the second kind of mini talk and talk about the microbiome. So as Dr. Korzenik had mentioned, there's several main hypotheses as to why inflammation develops in both the gut and liver in IBD and PSC, and that there may be an underlying mechanism in patients leading to inflammation in both areas. And one of these is the toxic bile acid hypothesis that I'm not going to talk about, but both the leaky gut hypothesis, where the hypothesis is that the gut is leaky when it's inflamed, and the serum or blood is exposed to microbial antigens, and this will result in an inflammatory response. The other hypothesis is there's a common inflammatory cells between the gut and the liver that results in inflammation, called the gut lymphocyte homing hypothesis. Both of these kind of center around the fact that there's a change or something in the lumen of the intestine, potentially a microbe or a microbial protein that initiates this cascade leading to inflammation. You can go to the next slide. So what is the intestinal microbiome? So the intestinal microbiome is symbiotic, meaning living together. In aggregate, it weighs about 3 pounds, and it includes not just, we commonly think of the microbiome as including bacteria, but it also includes fungi, viruses, other single cell organisms, as well as metabolites produced by these organisms. there's about 35,000 different species of bacteria that are in our microbiomes. And as you go from the mouth to the anus and in the GI tract, the contents or the amount of microbes per gram or milliliter of intestinal contents increases. So in the stomach, which is a very acidic environment, there's very few microbes. But when you get to the colon, there's 1 trillion organisms per gram or per liter of stool. You can go to the next slide. So what is the microbiome responsible for? So it's known to have several functional properties. So this includes metabolism of therapeutics, importantly, breakdown of nutrients, protecting the epithelial barrier, providing resistance to invading pathogens, and very importantly, development and training of the immune system. So it's thought that in many immune-mediated diseases, it's thought that the microbiome may play a role in why inflammation develops. Next slide. So it turns out if you do a study where you take mice that are grown in a germ-free environment, so picture the boy in the bubble, not being exposed to any microbes, and then they're conventionalized or exposed to the normal environment, and they're given a transplant of stool from either an IBD patient or a patient without IBD. If you do this, nothing really will happen to the mice. But if you induce colitis in these mice, the mice that get stool from the IBD patient will have a more severe colitis than the mice that get stool from a healthy control patient, suggesting there's some component or something in the microbiome that leads to this more significant inflammation. You can go to the next slide. So you might say, well, that's mice. What does that really have to do with me or my family who has IBD? Well, there is relevance here because the composition of the bacteria in the gut changed in the setting of IBD. And as Dr. Korzenik mentioned, it's changed in the setting of IBD and PSC as well. And it also changes based on different environmental triggers, such as diet, medications, and other disease states. And if we went through the odds, which we're not going to do, and we said, if we asked everybody what caused their IBD, there would be 35 different answers of what caused the IBD, but virtually all these can have an impact on their microbiome. So we think that this environmental exposure, whatever it may be, whether it was an antibiotic somebody used or eating a diet that they were on, or exposure as a child to an infection, this results in dysbiosis, or a change in the microbes in the gut. And in most individuals, nothing happens with this insult. But in a genetically susceptible individual, they will develop inflammatory bowel disease or inflammation in their intestine. You can go to the next slide. So which brings us to the question, if we manipulate the microbiome, can we heal the bowel or the liver in this instance? So there's several ways in which we can manipulate the microbiome. We can do this through antibiotics, we can do this through probiotics, and we can do this through a fecal transplant as well, amongst other ways. So are antibiotics effective in treating IBD? So as Dr. Korzenik mentioned, although there are individual studies that do show a benefit, antibiotics are not recommended given the limited benefit and efficacy of other therapies in most patients with ulcerative colitis or Crohn's disease. There's some subset of patients with Crohn's disease where antibiotics are used frequently and very effective. This includes patients with perianal Crohn's disease, so Crohn's involvement of the perianal region. I will say that it's very uncommon for patients with PSC and Crohn's disease to have perianal complications from their Crohn's disease for whatever reason, but it's not the typical phenotype that we see in patients with primary sclerosing cholangitis. In addition, antibiotics can be used for postoperative prevention in Crohn's disease. So a common surgery in Crohn's disease is to have the very bottom of the small intestine or the ileum or the very top of the colon resected when there's a narrowing or severe inflammation in that area. And it's going on an antibiotic called metronidazole immediately after surgery. Can prevent recurrence, at least in the short term. It's rarely used because of the effectiveness of other therapies and side effects of treatment. But again, that surgery is not as common in patients who have PSC, because there's patients who have Crohn's disease and PSC that typically have a colonic involvement, maybe with some small involvement, but doesn't typically lead to surgery in that area. What about patients with a J pouch or ileoanal procedure who have a new rectum created out of small intestine? In this instance, antibiotics are very effective both for treating acute pouchitis, so an acute infection of the pouch that responds well to antibiotics, or in some patients who have chronic inflammation in the pouch, antibiotics may be effective in this area. And as many of you know, there's been a lot of interest in studying the impact of antibiotics on PSC, irrespective of the inflammatory bowel disease. And some studies that have looked at this, primarily with vancomycin, but also with metronidazole, have shown improvement with liver biochemistries, although long-term disease progression with antibiotics or prevention of disease progression is still unknown at this point in time. You can go on to the next slide. So why not treat with probiotics? And probiotics are really attractive for many people, given that they're not a standard medicine. They have a very good safety profile. Unfortunately, although there's individual studies looking at probiotics for both Crohn's and ulcerative colitis, there's not a consistent validated probiotic that's been shown to be effective. And is this because we haven't identified the best bacteria, or would they be more effective early before a patient is diagnosed with ulcerative colitis or Crohn's disease to prevent the onset of ulcerative colitis or Crohn's disease, so to change the microbiota in that fashion? The only instance where they have been shown to be effective is in patients with pouchitis, so patients who have an ileoanal J pouch who have recurrent pouchitis. They've been shown to be effective in prevention of recurrent pouchitis. You go to the next slide. So what about treating with this? So this is what we're looking at here is a fecal transplant. This is kind of like the ultimate probiotic. Next slide. So what is a fecal transplant? So fecal transplant is a stool that's given from a donor to a recipient. Donors who give their stool are screened for multiple infectious diseases, as well as there's a social screen to make sure they're not high-risk individuals. And stool is processed and filtered prior to delivery. And most commonly, the stool is delivered by colonoscopy into the very beginning of the colon, although it can be given by capsules swallowed, or by a tube from the nose into the stomach, or by an enema. Fecal transplants are very effective for preventing patients who have an infectious colitis called C. diff colitis. And they're commonly used for patients who've had difficulty with recurrence despite antibiotics, or patients in the hospital who have a severe C. diff colitis that's not responding to antibiotics. There's intense research looking at fecal transplant in other disease states as well, even non-GI disease states, looking at the benefit of a fecal transplant. In studies looking at the efficacy and safety of fecal transplants in patients with C. diff colitis, the overall safety profile is very good. However, most of the data really has been in the last decade or so. So it's a limited data set we're looking at without long-term follow-up. It's very common for patients to get some GI side effects afterwards, like diarrhea, bloating, nausea. And there's always this potential to transfer virulent or microorganisms that can cause disease that can't be screened for with our standard screening test as well. And then, as I mentioned, long-term outcomes have not been well studied. Given the kind of the multitude of roles of the microbiome, there's been thoughts that the fecal transplants could result in patients gaining weight, losing weight, or other immune-mediated complications. There was one study, I believe, out of Emory that suggested that patients were more likely to develop arthritis after the fecal transplant. That has not been validated, though subsequently. You go on to the next slide. So if you read the headlines, there's some exciting headlines. Next, that fecal transplants cure Crohn's or ulcerative colitis. You can show the next slide. But what's the reality? There's been 3 studies in patients with ulcerative colitis. The data with Crohn's disease is more limited, that have shown a benefit. And there have been good studies showing short-term benefit with fecal transplant, although an intensive regimen is required. For instance, in one study, the patients got a colonoscopy up front and got a fecal transplant, then got enemas every day for 8 weeks with a fecal transplant. And the benefit is typically seen early, and the studies are stopped at that point in time. So it's not clear if a patient needs a maintenance therapy with this, or if the benefit is sustained over time. The other question is, what's the optimal microbiome to transplant into patient? That's still not known. Some of the studies that have shown benefit use a mixed donor stool, so to get stool from multiple donors and mix it together to potentially to hedge your bets on which donor is going to be the most effective for treating the inflammatory bowel disease. Next slide. So what about giving an FMT for PSC? And Dr. Korzenik actually did this study. It was published a few years ago. Keep in mind, it was only done in 10 patients. All these patients had IBD and PSC, but they did see that 3 patients had over 50% decrease in alkaline phosphatase. And interestingly, the patients who saw that benefit all had an associated engraftment. So we mean engraftment, it means that the stool that was in the bacteria that was in the donor stool was seen subsequently in the stool of the patients who received the transplant. So having a good engraftment was associated with a response. So this is kind of a proof of principle that manipulating the microbiome may be an effective strategy, both for treating IBD, but also, if not a treatment for PSC, at least improving liver biochemistries in patients with PSC. Next slide. So fortunately, the fecal transplants or manipulating the microbiome is getting easier and potentially safer as well. So there's new ways in which we can manipulate the microbiome that don't involve an enema or colonoscopy. This includes giving FMT by capsules, which we do commonly. There's a company that's making freeze-dried stool, so that it's stable at room temperature and potentially could be mass manufactured as well. You don't even have to give the bacteria, you can just give the filtrate from the stool that contains some of the metabolites, and that can result in benefit, at least in C. diff colitis. There's a therapy that may get FDA approved soon for treating C. diff colitis that is the bacterial spores. And so that would be an ideal scenario where if it's mass produced, is stable at room temperature in the refrigerator and can be taken as a maintenance therapy, if you would be able or episodic therapy would be able to manipulate the microbiome in that manner, or creating an artificial stool, so to speak. So putting together multiple organisms in a reproducible fashion. Next slide. So in conclusion, studying this interaction between luminal microbes and individuals is likely to inform us of the etiology of IBD PSC, even in the absence of a single organism causing PSC. Just understanding the interaction that the proteins in the gut have with the immune response may help us inform us of why inflammation occurs both in the liver and in the bowel. However, there's still a lot to learn here, and we're still far away from creating a treatment or identifying a mechanism. But over the last decades, the amount of research that has been done in this area is enormous, and it's growing every day. So I anticipate we're going to have new information coming out soon that will lead us to more information about why inflammation occurs both in the bowel and the liver, related to the gut or not related to the gut in the near future. Next slide. And I want to thank you. I'm happy to take any questions.
Thank you so much, Dr. Pekow, for that wonderful discussion, not only of the link when it comes to cancer, but also the microbiome. I think, as Dr. Korzenik said very well at the beginning, there's still a lot we don't know about PSC, but we do know the connection to IBD. So we have to start, I think, building from there. So thank you both once again. We have several questions that were entered in the Q&A box, and also some that were entered in advance of the lectures. I'd like to just start perhaps with a question which I think is very reasonable and one without a great answer, but Dr. Korzenik, one of the PSC partners, patient advocates and patients had asked, why are some people diagnosed with IBD either before, after, or around the time in which they are diagnosed with PSC? In particular, when patients sometimes are diagnosed with IBD even after a liver transplant, is there any clinical meaning to that? Does it portend any type of prognosis, or is it just unexplained?
So it's a really good question that is largely unexplained. So that sometimes people with PSC, as mentioned, will have very mild GI symptoms, but the colonic inflammation be quite severe. So they don't necessarily say, oh, I've got to get evaluated. I'm having 10 stools a day and bloody diarrhea. They might say, I feel fine from a GI perspective. And they have other problems that pick up a problem in the liver. So they get diagnosed with PSC. Once someone's diagnosed with PSC, everyone then would proceed to a colonoscopy because of that. So sometimes the diagnosis can be very close together because of that issue. But in other people, I see most of the people often before they have PSC, they have IBD and we're following them for many years, and then they go on to develop PSC. Less often it's the other way around, that someone has PSC first. So I do think that there's an important lesson there that we haven't figured out yet of why more often IBD precedes PSC. But understanding all of these things are really important pieces of the puzzle in terms of understanding this whole set of problems.
Thank you, Dr. Korzenik, very much. And a follow-up question, which is related from another patient, is a hot topic, I'd say, these days, which is it possible that there are more people who have PSC among patients with IBD than were previously recognized? And if so, what is the best strategy to identify these patients? And of course, along those lines, what can be offered if a diagnosis is made quite early, as opposed to when there are some clinical signs or symptoms?
You want me to try and answer that?
Sure.
So undoubtedly, because most patients with PSC, especially at the time of diagnosis, don't have symptoms related to their PSC. So undoubtedly, we're missing a fair number of patients who have IBD who don't have who have PSC but don't know it, or we don't know it. And there's been studies that have looked at, if you do an MRI on patients with ulcerative colitis, you pick up on more patients with PSC. I believe the rate is around 7% of patients with ulcerative colitis will have PSC in the MRI-based studies. The challenge is that that's expensive and I don't know about invasive, but time consuming for patients to go and have done if the rate is overall low. But ideally, that would be the best way to pick up on patients. A simpler way would be to routinely check liver function tests, although sometimes even that patients with PSC will have normal or close to normal liver function tests or subtle abnormalities that won't be recognized in advance. So it's a challenge for sure.
Thank you, Dr. Pekow. I appreciate that. That's very true. One question perhaps directed at some of the topics you discussed, particularly when it comes to colon cancer. A parent of a patient wrote in to say, my child has ulcerative colitis and PSC. Her doctors are not routinely ordering a colonoscopy, and how often should I be asking for a colonoscopy, which is a reasonable question. Perhaps it also gets at the topic of when should colon cancer screening begin for the pediatric range of patients with PSC and IBD.
Mm-hmm. So I actually don't know the data for pediatrics as well, but in adults with IBD and PSC, we recommend getting a colonoscopy at the time of diagnosis of whichever comes second. So typically the PSC is diagnosed second, and then every year thereafter. And I believe those recommendations are for pediatric patients as well. Josh, I'm not sure if you know the pediatric guidelines.
No, it's a really important question. I mean, I've assumed that the same thing pertains. Neither of us are pediatricians. So, but I think that we tend to scope much more than pediatricians do, because many of our patients have had the disease for longer periods of time. But I agree. I think anyone with the diagnosis of PSC should have an annual colonoscopy. The other thing is we don't really know necessarily in many patients how long they've had IBD, particularly with PSC, and so it could be that they've had it for a long period of time. So for all those reasons, I think even in pediatrics, it should be annually, but there is a little bit of a wiggle room because neither of us are absolutely certain about the data in pediatrics.
No, thank you. I know that the late teenage years already start to approximate the biology and the risks as adults. And so there's a gray zone there, but I agree with you both. Thank you. Dr. Korzenik, you had discussed to a certain degree the potential meaning, which is more speculative, of whether PSC is an autoimmune versus an inflammatory disorder, which is just for its own merits is quite fascinating because of how we categorize that and maybe some of the immunobiology. Do you have any sense as to whether that distinction could produce some breakthroughs or at least some line of inquiry that might help to get at the basics or the connection between PSC and IBD?
So certainly we think so. We're pursuing a number of specific hypotheses that we're very excited about. We may be completely wrong, but we do think that the data that we're really trying to go about this in a way that both looks at a specific hypothesis, looks at a number of important pathways, and then we're sort of twinning this or pairing this with a therapy. So we are looking at certainly bile. So when we say get all of these stool samples and oral samples, we're looking at bile metabolism and bile metabolites. We're looking at, we think, other pathways that we think are really important. One is certainly something called butyrate and there's something called short chain fatty acid. I'm happy to get into this in more detail, but it may get a little confusing. But we're also very interested in hydrogen sulfide. We're very interested in nitrogen. So these are not just sort of broad things. What we want to avoid doing is just saying, all right, well, this is up and this is down. When we do all of these studies, we're trying to say very specifically, this is what we think happens. This is the process, and this is what we want to reverse. And testing that out, both in clinical trials and also in sort of trying to understand what bacteria are there, what genes are there in the bacteria, what are they doing. So yes, we're trying to inform our studies with very specific hypotheses, test them, and see whether they might be correct. And really partnering with PSC partners in part to do these studies. So in the same way that we started this with this dietary study we did that some of you have heard about that did support the hypothesis, and we're very excited about.
Thank you, Dr. Korzenik. Dr. Pekow, there's a really great question, I think, that feeds off of your discussion of the microbiome, a very practical one, but one I think that PSC Partners Seeking Cure is always highly interested in helping to promote, which is, the question is from a patient, are research studies on the microbiome more difficult to recruit for than other studies? Just based on your experience in clinical care and also clinical research, do you have a sense for the ease or the difficulty in enrolling and recruiting for these types of studies, given the fact that there's such a need to make progress?
Yeah, that's a great question. Actually, patients are really interested in these studies and provide. And we generally, in terms of consenting or an interest in all our IBD and PSC studies, our response rates or consent rates are very high across the board. As patients are very invested in their diseases and want the scientists to make progress in studying their disease. Where we do have problem, to tell you the truth, is with stool collection, for whatever reason, getting, especially if you don't do it at the clinic visit, is getting patients to send stool back to us from their house. And I'm not sure if that's just if you had patients do other samples at home, if it would be the same thing, or if they don't want to handle their stool and send it in. But that has been an issue. But frequently when patients are reminded, they'll do it. But there is an interest in patients in participating.
Thank you. No, I think that practical issue we've run into here as well at Yale, and for multiple reasons, but you are correct, actually. So, thank you so much. Dr. Korzenik, a patient wrote in here with a good question, because there was a very correct statement at the beginning of your lecture about the fact that none, at least thus far, none of the typical medications that have been used, biologics and others, for IBD seem to have an effect on PSC. One counter question that was written in here is, how often do you see a negative effect on the liver from using standard IBD medications? And is that risk any higher or lower if the patient also has underlying PSC?
Yeah, that's a really important question. So certainly a number of the medications we use, whether it's 6-MP, azathioprine, or even infliximab, can, in certain circumstances, cause liver enzymes to go up and cause injury to the liver. but there isn't any indication that any of them cause PSC to worsen. So that's an important distinction, that and we monitor for those things, so that if liver tests are getting worse, we would stop the drug.
Thank you. No, that's helpful. And I think it's important for the PSC community to keep that in mind. There are always cases of drug-induced injury that can occur, but they are not necessarily higher risk by having PSC. Dr. Pekow, there are several studies and several questions that were raised about the risk of PSC and IBD, and also the risk of cancer when it comes to the genetic component for that risk. Several patients had written in advance of the lecture and also here this evening about the whether there are siblings that are at higher risk for PSC and or IBD and what effect that may or may not have on the risk of colon cancer. Do you have any thoughts for the patient audience as to the risk when it comes to familial diagnoses, and what do you typically advise your patients as to whether family members should be even screened for these if they don't have the known diseases?
Yeah, I mean, there is definitely an association between the two, and we do take care of some families where multiple members of the family have both IBD and PSC. I don't know the data. I'm not sure if you or Dr. Korzenik knows the data for risk of a sibling or child for developing PSC. For IBD alone, it's about 5% risk, specifically with your children. Unless your spouse has IBD as well, then the risk in your child goes up to about 50% in developing IBD. But we definitely see some families. We don't clearly know why this is, because this is the genetic association with IBD is relatively weak, meaning each gene conveys a small risk of developing disease. But there's definitely some families where there's a strong penetrance where multiple family members get IBD. With PSC, it's not as common to see IBD patients with PSC, so the familial association, I'm not aware of studies that have looked at that. I'm not sure if you know the data on this either.
There is one study, which I believe is still ongoing, looking at familial risk from Mayo Clinic. And they do have a large genetic study as well of over 1,000 patients. I know that I have one patient in which two siblings in the same family have PSC, and they certainly are interested in genetic testing, but I think that it is less common than we would otherwise expect. So.
Mm-hmm. And I don't know, there's not necessarily an associate, just because there's an association if your family member has a risk of colon cancer, that your risk of colon cancer is higher, even if they don't have IBD, especially if they're under 60 years old when they're diagnosed with colon cancer. However, having a sibling or a relative with IBD alone or IBD and PSC should not put you at higher risk to develop colon cancer alone without a family history of colon cancer.
And it does raise the question, sometimes when there's these families, you wonder whether it's a different subset of patients. So whether it's, in the same way that other diseases can not masquerade or cause something, celiac can cause liver disease, and that could be more strongly genetic. And also the whole issue with sort of a cystic fibrosis type picture can also be that, and that may be more genetic. So sometimes these families that are more closely genetic link, I think we need to look at a little more closely to make sure that it's not slightly different than PSC.
Mm-hmm.
Yeah, I think that's an excellent point, which I think even as clinicians and researchers, we struggle to understand, but certain things can look like PSC and may have a genetic basis that is different from the typical PSC-IBD presentation. Of course, this one is for you. Goodness. A patient wrote in that I attended the PSC Diet webinar recently for PSC Partners. They talked about more research being needed. What can patients do to push for more research on PSC-IBD and particularly the role of nutrition?
So great question. So the first thing is just being present at these seminars, being part of PSC Partners. And one of the things that I think that is wonderful that PSC Partners is doing is really trying in part to develop sort of, let's say, a culture of participation and research, so that we all can contribute, we all can participate, we all can contribute a stool sample. We can all contribute certain things that we we, whether it is participating in a clinical trial, whether it is giving your time, efforts, resources, any of those things. So all of that's really important. In terms of nutrition in particular, that's, we did this small pilot study. We're now in the process of looking at the changes in the microbiome that happened during that study. So most of those samples have been sent off, and then we're doing the analysis, and that will take a while. So seeing how diet impacted the microbiome, and does that tell us something in terms of who responded or didn't? So in terms of where then to go for research, well, in our efforts, we're looking at this, we're trying to figure out ourselves what our next steps will be and how do we follow this up. So I would say in terms of diet itself, we're on hold while we sort of evaluate, understand, and one of the fellows and now on faculty who was involved in this is on maternity leave. So it's taken a minor pause while we do these analyses, but we're very interested in following up on this, but whether it's this in particular or what other centers are doing, and really looking at how you can be part of the research community and moving this forward, in particular in clinical trials. There are a number of them going on. And so looking at what might suit your interests and offering to be part would be a really helpful process.
Thank you. I think that's a really great point, which is that there are myriad different patient experiences and patient levels of involvement, but there is, I think we would all agree, something that everybody can do to contribute in one format or another, in one study or another. So I think it takes us.
And I just want to add one little note. So we're very excited about our study, but we also are not looking at the idea that nutrition is likely going to be the only therapy, that we are hoping that nutrition will be one factor that helps modify the disease and improves things, and also gives an understanding of what needs to be changed. So we think it's a critical component, but we don't think that in itself it's sufficient. So we wouldn't say just do this and don't look at sort of the development of other possible ways of treating the disease.
Thank you. I think that's a very important distinction. Dr. Pekow, a question that is probably pretty general, although there's always individual patient circumstances, but in your opinion, somebody wrote in here, I think it's a fair question, how effective overall are drugs in treating someone who has pouchitis, perhaps in relationship to some of the other therapies and approaches you had discussed?
That really varies, and it runs the gamut. In most people who develop acute pouchitis, that when we talk about acute pouchitis, where patients feel well, they don't have inflammation in their pouch, and all of a sudden develop symptoms of urgency, diarrhea, increased frequency of bowel movements. Those patients who have acute pouchitis respond very well to antibiotics. Typically, we'll give ciprofloxacin and metronidazole as antibiotics, but others are effective as well. For patients with chronic pouchitis, some patients will respond to antibiotics as well, but need to be on antibiotics chronically. There's a subset of patients who don't respond to antibiotics, and this gets into an area that can be more of a challenge to treat, where we go back to and treat patients who are not responsive to antibiotics with medicines that we use to treat their inflammatory bowel disease. So infliximab or adalimumab or vedolizumab, which just had a trial that was shown to be effective. And in some patients they respond, in some patients they don't respond, just like in patients with inflammatory bowel disease. But it can be a challenge when patients have gone through numerous therapies already and are not responding to antibiotics to get the pouch under good control over time.
Thank you. Thank you. I think that's very helpful. Perhaps the last questions, I'll open this up to each of you, the ever popular topic of oral vancomycin. I think a very appropriate question by one of the listeners or attendees is, what are the potential risks of using vancomycin? It seems that vanco use was played down to some degree in the talks, but in some patient experiences and Facebook groups and such, that some patients do have reported improvement in the IBD itself, and sometimes liver enzymes as well. Some providers are willing to prescribe, others are not. Is it possible to describe to some degree or briefly the concern, especially in VRE, and why this treatment is controversial?
That was for me or for?
Oh, it's open.
Either.
So, yeah, so I'll take, certainly, we were very interested in that. We did a study, I think Dan Pratt and I did a study 8-9 years ago that we've tried to publish, but there wasn't a placebo group, and we should sort of resubmit it. But we treated people with high doses of vancomycin for a year. So I think it was a reasonable study, and we were looking at some had repeat biopsies, most had repeat MRCPs, and so really looking at short-term and longer-term benefit. We didn't see anything. And there's some data out there, particularly in some of the pediatric series, that look very promising. The question is it a longer-term benefit? And some of the data suggests it isn't. I've had patients who have been on vancomycin for other reasons for longer periods of time. They say went on C. diff, they responded really well and were on it for longer periods of time, and their GI disease improved. So it's not many, but somebody who was on vancomycin for an extended period of time, their alkaline phosphatase was low, but then they subsequently developed PSC. So I think that we're all intrigued by it, and we think it may be of benefit, but we also think that the data isn't there because we need better studies, we need longer term studies. And so it's like everything in PSC, anything that may be suggestive, we want to welcome, we want to study it. We also want to be skeptical because URSO, we thought this is the answer, this is going to be great. And then not only did URSO not help, but in some people it may worsen the disease. So it's something we really need to understand and be skeptical but encouraging.
Yeah, I guess in terms of risks, although vancomycin is generally well tolerated, there was actually a recent study where they took patients who had C. diff in their stool but didn't have an infection, so carriers of C. diff, and they treated them with vancomycin. And it not only did it change the microbiome as expected, but there was a high rate of developing vancomycin resistant enterococcus. So you can breed these resistant organisms. So if you get sick with one of these organisms, it can be harder to treat if you have a systemic infection in the future. That's a potential risk. There's always this unknown risk. If you alter the microbiome, are you putting yourself at risk for other possible disease states or worsening the colitis or so forth over time? And we don't know the answer. Those are theoretical for the most part. We don't know if that's harmful or not.
I think that's correct. And particularly patients who are getting into the transplant arena, I know that the level of concern for resistant bacteria certainly gets a bit higher. Well, I want to thank Dr. Korzenik, Dr. Pekow for such a wonderful session and for the lively discussion and for the really great content. And with that, I will pass it over to Ricky Safer. Thank you.
Thank you. Thank you so much, Drs. Korzenik, Pekow, and Assis. There were so many unanswered questions on this topic of the PSC-IBD connection. And I want to thank you for your expert explanations of this complicated situation and also insights into future research directions. It was really a wonderful, wonderful discussion. Thank you so much. I'd like to quickly review some future events that are coming up. As always, please think about joining our patient registry and mentor program. The person who asked about how did they learn more about clinical trials, if you join the patient registry, you will be kept up to date and everything that's going on. Listen to our monthly podcasts. Visit our website if you want to learn more updated information about COVID-19 and vaccine information for PSC patients. As always, sign up for a mailing list and follow us on social media. If you are Canadian, you can also visit the pscpartners.ca Canadian site. For some of our following webinars, we hope you'll join us. They're all from 6 to 7:30 p.m. Mountain Time. Again, we had mentioned that we're going to reschedule the Living with PSC Psychosocial Stresses and Strains Coping Strategies for Patients. We also, on September 7th, will be doing a coping session for caregivers. And again, another opportunity for learning more about clinical trials. September 21st, we're going to have a webinar on the clinical trial landscape in PSC, current and new opportunities for patients, which will be fantastic. And we're bringing back our Zoom room support groups, again, all from 6 to 7 Mountain Time. Sometimes they go over another 30 minutes if the group wants to keep talking. So August 23rd will be for PSC patients pre and post transplant ages 18 and up. September 13th for those living with loss. September 28th for spouses, caregivers, and parents. And these are open to everybody within those groups. I also want to put in another push. If you haven't already joined Walk 83.01, please join us. It's our second annual fundraiser. It started July 9th and it goes through September 30th. You can walk, bike, kayak, however you want to add up your miles. We hope you'll put together a team if you don't have one already. Our goal is to raise $120,000, which will support 2 research projects for 2 years. So please join us. So thank you again for joining us, and we hope to see you again. Thank you.